Our goals today are to educate you on the many benefits and cost-saving capabilities that direct primary care has to offer, as well as to inform you of our own local efforts to provide direct primary care services to Southwest Michigan.
Take it away.
Thank you, my friend. So do you mind if I ask just really quick? Obviously this is targeted towards healthcare workers. How many doctors are here? Okay, good. Very, how many nurses? Wonderful. Everybody else in healthcare in some form? Okay, wonderful. Don't be surprised, they're targeted a little bit specifically to physicians, but this is applicable to anyone who's in the healthcare sector. So again, my name is Dr. Chad Savage. I'm thrilled to be here and that you guys all came out on a nice August day. So I'd like to start with the concept of, as physicians, why did you go to medical school? The sad truth is, as Senator Colbeck mentioned, burnout is becoming a big thing, and the real reason for that is because of the insurance-based practice of medicine. In the insurance-based practice of medicine, physicians are massively overworked. Are there any other primary care doctors here? All right. Oh, wonderful. You guys can attest to this, your patient basis. I am an internal medicine doc. I used to practice in insurance-based practice. I had 3,500 patients assigned to me. It is very common nowadays for primary care doctors to have 2,500, 3,000, in some cases even in excess of 4,000 patients. And the sad truth is that is almost impossible to give the quality of care that we are capable of giving when you're that overburdened. And when you're that overworked, what do you get? You get burnout. You know, to be compassionate, to be empathetic, you can't be miserable yourself. So we need to care for our care providers. And being overworked is not conducive to that. The sad truth is when doctors are overworked, what that means for patients is long waits for care. State of Michigan's a little better than this, but nationally the average wait time to see a primary care physician is now 24 days. Just a couple years ago it was 19 and a half, and before that it was 18. It's consistently going up. And when people have to wait that long for their care, unfortunately, they get to wait more when they finally do schedule their appointment. Studies have now shown that patients must dedicate 3 hours to a patient visit, meaning time to drive there, waiting in the waiting room, waiting in the exam room, so you see the doctor, then they get to wait for checkout, they do checkout and they drive home over 3 hours. And that's something called opportunity cost. It's the value of that patient's time. And it's been shown that in America, we waste $52 billion with a B every year in lost opportunity costs, meaning the value of their time that's spent waiting in our waiting rooms instead of at work or with their family or whatever it is that they want to do with their time. And then after all that waiting, unfortunately, they're graced with 8 to 10 minute office visits, quick, in and out, distracted. Doctors, as you all know, we are massively distracted by the bureaucracy we have to deal with. All the various payment systems, the value metrics and such. And it's been shown that we spend twice as much time documenting our visits than meaningfully interacting with our patients. And sadly, it's worse than that because there are intentional conflicts of interest that are injected into the system through the payment model. And the one I classically reference is the high-tech utilization rating. You guys remember what that is? You guys get that in any of your contracts? That's where they rate you based on how many MRIs you order. And if you order too many MRIs, it's ding against you, irrespective of whether they were justified in the ordering. And if you order too many, it can come back and decrease your value metric, and you can get paid less. So that's a conflict of interest that directly pits you against your patient and should never exist in the healthcare system. Now, I've never seen a graph that more succinctly explains what has occurred in the healthcare system than this one. So let me just take a quick second to explain it. This is referencing a 4-decade period of time from 1970 to 2009. And what you can see here is this brown line. This is the number of physicians in the United States. And as you can see, it's relatively stable. There's a slight upslope, but it's pretty stable over time. The yellow is the number of administrators in the healthcare system during that same time period. And as you can see, there is a veritable explosion of administrative positions, administrative expense, which is essentially bureaucracy that has been injected into the system. And this black line, this is per capita spending. This is how much each of us spend on healthcare each year. And as you can see, it's much more tracking with the administrative burden than it is with the physician supply. So much so that by 2010, according to the U.S. Department of Labor and Statistics, There were 4.5 million Americans whose job title was healthcare administrator, and they were managing 700,000 to 800,000 actively practicing physicians. To get rid of that fallacy that we are the problem, between 1998 and 2010, when adjusted for inflation, physicians' salaries went down 15%, while the overall health system costs exploded 75%. So we actually made more when the system costs less. So our salaries are not driving this cost inflation that's being seen. So a lot of people say, well, what happened, right? What happened? Well, quickly, it all started when the insurance-based model became employer-based in 1947. During World War II, there was something called the Stabilization Act. There was a shortage of labor. Everybody's overseas fighting the war. Because of that, supply and demand, there was a low supply of labor. Labor costs were skyrocketing. So employers went to the government and petitioned them and said, you gotta do something. It's costing so much to hire these people, we must do something. The government said, okay, time of war, dramatic measures can be taken. We're gonna put a freeze on all wages. No one can make more than they are making today until the end of the war. And the employers were fully staffed, went, yay, this is great. However, the employers who had open positions said, oh, wait a second. I need to hire someone here. Normally, I would offer more salary than my competitor to attract them away, but I can't do that anymore. I wonder what I'll do. I know, I'll give them a health care benefit. And the government said, well, yeah, okay, that's fine, that's not new wages. So it got linked to employment. That's when it got linked to employment. And the supply and demand in the system started getting really screwed up as people started overutilizing, thinking healthcare was free because it was buried in their employment costs. Well, this got so bad that in 1973, the government passed what was called the HMO Act. Everybody thinks of HMOs as being an insurance construct. It was actually created by the government. And a dangerous divide occurred in 1973 when insurance companies crossed the line from paying for medical expenses to managing medical care. So this is where they ceased being simply a financial institution. And this was exacerbated in 1982 when the patient was totally taken out of the payment system. Ken and some of the docs who've been practicing for a while can remember usual and customary. Prior to 1982, the patient paid the doctor and then submitted the bills to be reimbursed from the insurance company. And it seemed like a superfluous step, and probably was, but they at least looked at the bill and cared about the bill. After 1982, they ceased caring about the bill. They started going, well, yeah, I guess it was $3,000, but I only paid $5, and so they stopped thinking about how much it cost. And again, going back to the pay discrepancy, we got blamed for the exploding costs, but as you can see, and as I mentioned, our pay actually was decreasing, adjusted for inflation during this time period. Now, and what does this now feel like? Well, this is the 800-pound gorilla of the third-party payer system, insurance company governmental payment system, that now accompanies us each day on each visit with each patient. And they can tell us how many patients to see, what questions we can ask, and even dictate our care, or the care that we can provide. Now, I wouldn't bring up the problem unless I thought there was a solution. At least part of that solution is something called direct primary care. So people say, so direct primary care is a membership model of care, at least for primary care, where people pay a low-cost monthly membership for rat price services for a primary care office. It's low cost, it's budgetable, it's predictable, it's basically like a gym membership. And in fact, most of the software systems that we use in direct primary care are designed exactly that way. It pings out to an insurance card every month and the people don't even have to think about it. So in a membership model, it includes all the office visits, wellness visits, sick visits, whatever it is. The person comes in, there's no co-pays, there's no fees. They just come in and they use us when they need to use us. And why is this so important? Studies have clearly shown that when you increase the burden of patients by increasing the amount that they pay for office visits, what do? They do them less. Now, this decreases pricing and costs spent on primary care services. But that savings is doubled in new costs of hospitalization. And that is because people are presenting to us later and at more advanced stages of illness. So they end up so sick that they have to go into the hospital. And so this is not only a financial toll, but it is a massive impact and human burden on those people. These are people getting sick because they can't afford their care. In this low-cost monthly membership, we also include all in-office diagnostics. EKGs, spirometries, pulse oximetries, strep tests, flu swabs, urinalyses, whatever it is that we would normally do within the context of a normal primary care office, we include in that wrap price. So people aren't scared to come in and get an EKG. Well, won't that be an extra $50 or a spirometry or something of that sort? We just do it. We include all in-office procedures, cryotherapy, joint injections, skin biopsies, whatever it is that we need to do, we just get it done. And what I call virtual home visits. It's also known as telemedicine. Most of you probably know what this is. It's a lot of big buzz in the medical community now. We all know this is the future. That we can use technology to allow patients to access this in ways they never could before. So no longer does the practice of medicine have to be solely limited to the physical confines of your office. For about 40% of what we do in primary care can easily be handled remotely. And even though I use the example, which I'll talk about in a minute, of acute illness, the actual biggest potential I see for this is actually chronic disease management. And I'll use the hypertension as an example. So if you have hypertension, national standards of care and you're on medications is we're supposed to be checking you about twice a year. And if you're on certain drugs that could deplete electrolytes, we should be doing a BMP periodically and checking that. So we have the person come in from home, and we saw them once a year for the physical, right? But they're totally asymptomatic. We only have them in the office, so our time is valued for monitoring their services, their disease state. So we have them come in from home, and as you guys know, there's a big push towards ambulatory blood pressure monitoring, because the in-office monitoring may not be as accurate because they come in from home feeling great with their little sheet of paper, and they put it down on the desk, and it's got all their numbers from their blood pressure they've been monitoring. Great. Well, we walk in, and we've got their BMP results, and we place that down on the desk too. And we all look, and we look at the numbers. Your numbers look good. Yeah, the numbers look good there. Blood work looks good. Okay, great. Well, let me put my stethoscope on your chest so I can make sure I can get my coding in. You know, this person, I hate to say it, but this person's totally asymptomatic, and you physically examined them before. There is a small chance that you may stumble onto pathology, and we all have cases that we can explain where that has occurred. But the vast majority of the time, that is simply going through the processes to make sure you got your check mark so you can get your 213 or 214, whatever visit level you're going to code for. That could so easily have been done remotely. They could have had insomnia some night, emailed you their numbers at 2 a.m. as a primary care physician. We get it the next day. We look at the numbers. We email them back, say, oh, your numbers look great. Blood work's great. Fine, we will physically see you back in the office for your wellness visit in 6 months. That is quick, that is efficient, that is a much more appropriate utilization of our time. So the classic example I give is poison ivy too. So for the acute disease management, you shouldn't be throwing antibiotics at everybody. You know, that's some people get confused by that when they say that. They think, oh, so somebody calls with 2 days of sniffles and they want to put on vancomycin. You know, obviously that's a bad idea. Okay, that was the humor of the absurd. But I use a classic example of poison ivy. So a patient is at home and they wake up on a Saturday morning and they've got this itchy rash, and they were in the garden the other day and they think, it's Saturday morning, and of course this is the day I'm going to get poison ivy. So they're itching away and thinking about it, like, I want to go see my primary care doctor on Monday for this, but oh man, I know it takes a long time to get in there, and I'll be lucky if I even get in this week. This is terrible. I know, I'm going to the ER. So now you have a massively inappropriate utilization of ER services. Our patients, they pull out their cell phone, hold it, take a picture. They send it to us. Hey doc, got an itchy rash in the garden yesterday. It could be poison ivy. Why, that does look like poison ivy. Let me call in some triamcinolone cream for you. Let me know if you're not feeling better. Quick, efficient, good care. Wonderful for the patient, good for us. Why? We've got a history in the garden itchy rash. We've got a physical, high definition picture from the camera that incorporates into our record system. We got a treatment plan. Here's some triamcinolone. Follow up, let me know if you don't feel better. That is good care. And it's wonderful for ourselves, it's wonderful for that patient, it's also really wonderful for a third person who I didn't mention. And that's that really ill person who's just discharged from the hospital with congestive heart failure, who's coming in on Monday, and you were going to have to rush through their visit because you had to get to that poison ivy case. Well now, because they allowed us the flexibility of limited time resource, we get to put more time into that person who really needed us, and we can efficiently manage those who could be managed remotely through technology. So a lot of people say, oh, okay, you know, how do you get this kind of accessibility? Because most direct primary care practices offer same day or next day availability. And the reason why is we very intentionally do restrict the number of absolute patients that we see. So again, this is a reference to the average doctor's office, usually about 2,600 patients, more than that in some practices, as was mine. And most direct primary care doctors limit our practices to under 1,000. Most docs in that range are about 600 to 700. So you can see here that when you have a more restricted patient base, you can give them creme de la creme care. Because you just say those numbers and it's one thing, but to see the visual of the difference in burden, that's substantial. That doesn't mean you don't work hard. I work really hard for those people. They are getting creme de la creme care. They utilize us 4 times as much because they're not dissuaded by the costs. And people say, well, how could you make that work? How can you see 700 patients, charge them really low monthly rates, and make it work? So we save money in several levels, and one level is on ourselves. We actually don't charge exorbitant rates. So this is something I call DPC math. So in an insurance-based system, if you charge $1, the national collection rate is right around 60 cents. 60 cents on the dollar that you charge. But the problem is the collection of that 60 cents was not free. You had to pay billers and coders, so you probably burn up at least another 40% of that 60 cents on billing and collection. In fact, it's probably worse than that, but this is reasonable levels for estimation. So you have 60% of the 60 cents, which means on the dollar originally charged, you are only collecting 36 cents that actually goes to patient care. In a direct primary care model, you're getting paid at the time of service, or you're in a set payment arrangement. So the collection rate is actually very close to 100%. And the cost of collecting that is very close to 100% too. It's actually technically 2%. That's a credit card transaction fee. So you're collecting 98 cents, essentially $1, 98 cents on that original dollar charge. You're losing 2% to the credit card transaction fee. So you have 3 times as much of that dollar going to medical care than when you bill it out through the standard system. Now that's a lot, right? You know, unlimited primary care, all your office visits, in-office diagnostics, in-office procedures, telemedicines. We combine that, and I'll get into this in a second, with discounted meds, labs, imaging, other services to try to give great rates and save people money. That's got to cost a lot of money. Well, it's a lot better than you probably think. The St. Joe's docs actually offer an annual discount of 1 month off. So what you can see is that, first of all, if you are so blessed to live to 99, you are free. So that's you get to the centennial mark. Congratulations. But this is so neat. A family is as low as $150 a month for unlimited medical care and everything that they do. And if you break that down to a daily basis, that works out to $4.25 for unlimited primary care, which it makes me ask people all the time, how much do you spend on coffee a day? It's right there. So other ways that we save, as I alluded to, is by having better primary care. You have better access, which means you decrease ER overutilization. And ER docs actually, it's funny, burnout rate amongst family docs is right about 60-65%. It's one of the highest burnout rates. It's second to who? Anybody know? Who's number 1? ER docs. They're the only ones that have a higher burnout rate. And you can tell me if you think this is true or not. But I think it's partly because they're acting as family docs. They went in to be ER docs. I mean, they saw McDreamy and the others, and they wanted to be them. Well, okay, no. But, they went into thinking they were going to be doing true emergencies, and instead they're doing runny noses and stuff, which is why we went into the primary care. We like that stuff. We love runny noses. Mucus is cool. But anyway, so we should be leaving him to actually do what he trained for, which is the truly urgent, and we should be handling what we were trained for. But instead we're doing bureaucracy. So by having better access, less bureaucracy, we get to keep people out of the ER and in our offices. We combine this to maximize our cost benefit with direct contracting with labs, LabCorp, Quest, and others. And what we do is we get the prices that they charge hospitals, and then we give them to the patients who pass it through. We just act as a financial pass-through. They can't get these prices on their own. So we give them access to price points that they can't get. And if you have a high deductible plan, or if they do, they're paying the fake prices that are charged throughout the system. $80 for a CBC. And I'll get to that in a second. They combine it with low-cost imaging, low-cost medications. It's legal in the state of Michigan. Anybody who's an oncologist knows this. You can dispense to your patients. Well, we decided to take advantage of that too. You get an additional license. It's not that expensive or hard to get. We purchase from the same distributors as CVS, Rite Aid, and the other places do, but we just don't give them the 2,000% markup that they have at these places. So we make medications much more affordable to our patients. And then, again, we combine it with all the in-office testing that normally we charge separately. So here's some examples. So I mentioned what prices can you get laboratory testing, and just look at this and let it sink in for a minute. Before I did this, I had no idea these things could even, I was stuck even as a physician to thinking there's some crazy guy in the back room tilting beakers and looking at every slide of a CBC and counting cells. That is not, it's all automated. It's very cheap to run a CBC. They charge the St. Joe group $2 to run a CBC. They can do a CMP comp panel, $4.50. If you start adding this up, you guys all know that we don't just order a CBC. We order a CBC, and a CMP, a lipid panel, a TSH, we order them all. And on each of these, if they're saving 60, 70, 80 bucks, you on each of those, you can easily save many hundreds of dollars per blood draw. And that 6-month follow-up check for the hypertension follow-up that I mentioned, instead of 50 bucks for a BMP, they pay $3.40. So it makes access. We have a lot of people who can't afford medical care for going in. So not only do they not want to pay for us, they can't afford us, they end up in the hospital, but they can't afford this stuff. Well, that's ridiculous. This stuff is not expensive. We're bringing it affordable. We are the biggest area of growth in the direct primary care services are the underinsured. People who can't afford their medical care. We get a lot of working poor who are coming to us, and we're the only source of medical care. That's not ideal, but that's the reality. And the in-office pharmacy. So again, look at this stuff. You can get Norvasc, a couple years ago, that was a name brand. A month of Norvasc for 27 cents. Z-Paks for $1.47. Actually, we're getting them under $1 now. Prozac, 47 cents. Zestrol, now everybody knows, I love this one. So this great blood pressure medication, hypertension, renal dysfunction, diabetes. Dr. Fisher's really excited, an old nephrologist there, he loves this stuff. So you can treat hypertension for an entire month for less than the cost of a single gumball. And we do flu shots. They actually, this group, actually, I'm sorry, I carried this over from one of my presentations. We charge $9.99. They include it. They include tetanus shots and flu shots with their membership. They don't even charge for that stuff. And this is some of the rates that they're getting on imaging. So they're doing lumbar spines for 370. Do you guys mind if I ask where you got that price? The MRI price? Because actually, it's really hard to get pricing, and those are like trade secrets. And I'm serious about that. They treat them like trade secrets. Very hard to get what actually rates are on charge rates. So according to healthcosthelper.com, the average rate in the state of Michigan for an MRI in 2014 was $3,500. So they can get them for as low as 376 bucks. So the amount of savings they can get in one test, one MRI, you could see them for many, many, many years. They have the CTs, the ultrasounds, you can see the pricing. So just quickly, I want to go and say that one of the beautiful things about having all your primary care covered is it allows for not scary or bad ability to get less expensive medical coverage. That is where a lot of the savings comes in. So let me introduce you to the Johnson family. This is my hypothetical fictional family for whom I went out and obtained legitimate insurance quotes. So the mom and dad are in their early 50s, the kids are largely in their teens. So if you go and you do not have a subsidy, you're not getting it buried in your employment costs, and you buy an insurance product on your own today, and I use this zip code, so this is local. If you get a Blue Cross Blue Shield Gold Plan PPO with a $500 deductible, so this red here, this is premium, this is what you pay every month for your insurance, whether you see a doctor or not. This is what you have to pay before you can get this thing to pay for anything. So this is what you have to pay out of pocket, the deductible. And then a lot of people think, I went through my deductible, I don't have to pay anything more. But we all know that's not true. Then you have co-insurance, co-payments. You have to pay, these people are still paying, this is a 80-20 plan, which means they pay 20% of all the bills beyond that $500, which they pay 100%. So this means this family would be spending close to $33,000 every single year, even if they never saw a doctor, just on their insurance coverage. And what's so sad is after all that, they still are potentially liable for over an additional $10,000 if they got really sick. And if you're paying 20% of the bill, and most of the bills in medicine are false, and I could go into that and explain how the pricing is not real, but I know that'd be another couple hours. If you have a major, surgery and you're in an ICU, you can easily have charges over 100 grand. So if you're paying 20% of a 100 grand bill, it's 20 grand, that would blow this up. So you would use this all. So if you would consider the worst year of your life, you max out your insurance products, this is what it looks like. So this family would be paying almost $45,000 in that year, and in a bad year, and in a good year they're only paying 33.
I'm sorry, you're saying that's premium based on what premiums per month?
Well, these are actual Blue Cross Blue Shield quotes. I went to ehealthinsurance.com. I put in the ages of the various people, and you get a list of quotes. Anybody can go and check me on this. And so that's the premium for. So this is different
So
plans.
you're saying that's $11,250 per month for the family?
No, I'm sorry. This is annual. This is annual. 30.
So what's the 11?
Yeah. Oh, yes. Well, yep. That's right. So I'll come back to that and I'll show you what it is on a daily basis. So this is your annual fee. Now a lot of people, this is hidden. They don't know it. I get it from my employer. I only pay $500 a month, but your employer kicked in what? Now people think, well, that's good because I didn't pay it, my employer paid it, but yes, you did. They could have given you that as wages. They could have given you that as money in your pocket, but instead they gave it to you as a healthcare benefit, something called deferred wages. So if we paid less on healthcare, you'd have a lot more money in your pocket. Silver plan, bronze plan, so think about this. So if you go from this plan, the gold plan, down to a bronze plan, they have already shaved off $14,000. But people go, yeah, but now you got a $14,000 deductible, right? Well, the interesting thing is the $14,000 deductible is actually the legal max for what's called out-of-pocket maximum. So in this plan, if you use the entire deductible, and you have to do that before the insurance company covers anything, but once you've done that, they cover it all. You have blown up the out-of-pocket maximum. So you could pay $14,000 in a bad year, but this is $14,000 you would have spent every year no matter what if you get this plan. So the key is they say you're at risk for this. You could potentially pay $14,000. I don't say that's at risk. That's a benefit if you compare it to this. You have a potential opportunity to save money here. If you spend $2,000 here, then you save $12,300 compared to the gold plan. So if you actually look at this mathematically, and if you don't get a subsidy or it's not during your employment costs or something of that sort, if you can choose your own plan, you are never incentivized to buy this plan. In the worst year of your life, the only thing you've done by buying this plan, the gold plan, is guarantee yourself financially the medical worst year of your life every single year. You will be paying as though you maxed out this plan every single year for as long as you have that plan. Now this is something most people don't know about. I consider this the best kept secret in medical finance. And this is a health sharing program. There's 4 majors. There's Liberty Health Share, there's Christian Healthcare Ministries, there's MediShare, and the one I'm personally in, which is called Samaritan Ministries. 3 of those you have to be an actively practicing Christian to be a part of. This one you do not. So these are ACA compliant, Obamacare compliant coverage products. So these cover things like hospitalization, major medical issues, with the exception of pre-existing. So these are not for everybody. There are some limitations. But if you are relatively healthy, these are a wonderful option. And they have essentially the equivalent of a $1,500 deductible. They do not call it a deductible. I'm not their representative, okay? So, but these are similar. That function, so this functions similar to a premium. This functions similar to a deductible. They are not the same thing. It is not an insurance company contract. But again, they function very similarly in how they cover medical bills. So if you simply change how you pay for your coverage product, not actually alter care, let's take a look at this. So if you add in direct primary care, so you're making it, so remember, direct primary care is trying to get you good prices on it, and you're trying to decrease your costs. So why is that advantageous? If you have a $14,000 deductible, this is 80% of your medical care. This is unlimited primary care. And when you have this, they get good prices, so you're much less likely to use all of this. So they become almost part of your financial plan. And Liberty actually currently partially pays for direct primary care, so they could have unlimited primary care down here for their entire family. So I was looking at this originally and I thought, how many years of unlimited primary care would it take to make up for the price difference in this coverage product versus this coverage product just by changing for 1 year? You could have unlimited primary care for almost 4 decades by changing how you cover your insurance product for 1 year. And if you didn't dump that back all into medicine and used it for other purposes, over 10 years, you could buy a very nice house with the savings you get by just altering how we pay for coverage. So I'm going to hand this over to Michael. He's got some other specific examples.
just want to thank you for coming. I know it's tough over the lunch hour, but I want to show you what we did as a business. So what we were looking at the end of 2016 is we were looking at renewing our insurance and continuing the traditional PPO plan that we've had for years in our practice. So as you can look at this, this is a large number for a small practice. Big amount of money we're going to be paying out last year, or coming into this year. And this covers 23 families, or 23 lives rather, and our deductible was this, so you can see that. So what we did is we made a transition, and we said, let's look at a higher deductible plan. It's actually about 3 times of what this deductible is. And we said the premium's going to go from 153 down to 97,000. Huge savings for us. And then we said we're going to couple that with a direct primary care membership for those patients in our, or those employees in our practice that we take care of. So this is what we consider a value add. So a lot of our employees just come and see us and they're happy with that. This resulted in about a $41,000 savings for our practice. And if you look down here, 27% savings. That was a huge savings for us as a small business. And this is actually quite consistent with what we see, what's been reported nationally as far as how much a business can save transitioning to this type of a setup. So this was a really impressive number to us, and so it's pretty consistent with what's happening out there. I'll hand it back to Dr. Sander. That's almost
So I mean, what I love about that is I'm creating, I'm going out and getting quotes and everything. This is them. That's about 50, to 40 grand plus a year that they get. That would be like a $10,000 bonus to each of the docs at the end of the year. And that's honestly a 4-doc practice. This is not a major corporation. Earlier today we did an employer's presentation, and they're sizable corporations. You can magnify this across the entire corporation. The savings could be just unbelievable numbers. And by the way, that doesn't alter your care from the doctors at all. In fact, I'd argue it's better care. So a lot of people say, okay, well that's great, all about primary care, but I'm a specialist. How will this affect me? So, and specifically, a lot of you guys are probably people who the St. Joe docs refer to. So will it change the family physicians of St. Joe relationship with me? And the answer is only to the better. So you will have better access. So if you have an issue and you see a patient and you say, you got to get back in your primary care doc, or I need to call them up, you'll have much better access to those doctors than you had in the past. It'll largely be the same referral patterns. If you give great care to their patients, they will likely continue to send to you. You are a reflection back at us on specialists. We get judged by whether you do a good job. If we send them to a doctor who's quick and flippant, they tend not to like us for doing so. So again, there's a great incentive. The one product that can give us a real problem, some of the HMOs do, but specifically BCN. BCN, they mandate that they pay your doctor for your doctor to make a referral. Now that doesn't make any sense, right? They should love us. They don't pay us. They get the premium, which supposedly bakes in the primary care, but the patient's paying for the primary care, so they get to keep all that money, right? That makes great sense. Nope. So why would they do that? They must have their tentacles into the practice of medicine. They are much more incentivized to prevent you from ordering an MRI on this cost spectrum than to even bother. The primary care is so cheap in the grand scheme of things that they consider that just almost a throwaway expense. So they're better off manipulating that primary care doctor's practices than to wash their hands of it. So other aspects, if you're an imaging center, they got good prices. Give them even better prices. Work with them. We are doing this for our patients. We are doing this to make care affordable for our patients. So we always forget that, but that is, well, not always, but this is why we're doing what we're doing. Give them great prices. Prompt pay discount. A lot of people say, well, how do I do that and not violate my insurance contracts? Well, there's something called a prompt pay discount. It's perfectly legal to have a specific cash pay rate that you offer everyone, including the insurance companies. People say, yeah, but that's less than my Blue Cross Blue Shield rate. Well, you can offer to Blue Cross Blue Shield. If you say, if Blue Cross Blue Shield, this person came in, if you pay me immediately at the time that they're there, I will give you that rate. Are they going to do that? No. Then you're lucky to see that for a couple months. So no payer does it. No payer pays at the time of service, which means you now have perfectly legal the ability, and again, confer with your attorneys, but the ability to give people who truly need that assistance wonderful rates at the time of service. What about other specialists? Give great care, as I mentioned, and then offer discounted prices. You can help us in the direct primary care community very well by essentially replicating what we're doing. It does not mean you have to get out of the insurance industry. You can do it. But it is perfectly legal to give the Medicare rate plus 1%. You will make more money than you do on Medicare. So Medicare has some weird stipulations that say you can't underprice that. But you can give people that price. You're not undercutting Medicare. This is actually a great rate for cash pay patients. And you retain more of it. Because if you don't have the billing and coding and other hassles and costs of collecting that Medicare rate, you retain more of those dollars. Now there is something you say, well, gosh, I really want to do this. I want to do this on a broader scale. There is something called a Premier Provider Group, and the Kempton Group is actually arranging this. They are making this so that businesses can access you in a cash-friendly way, and you can give those rates to businesses. And the Kempton Group, which is right here, if you want to learn more about it, I don't have all the details, but it's very novel. It's giving specialists the ability to engage in the free market cash pay prices that we're doing, but there are not enough of us yet, usually for most specialists, to just abdicate the insurance payment system altogether. This allows you to start to dip your foot into these kind of waters. So you may want to look into the Kempton Premier Providers Group. They essentially function as another payer, but they're really just the go-between for essentially cash payments for businesses. So DPC is part of the solution. So in the current insurance-based system, primary care doctors and doctors in general are massively overworked, too many patients. In the DPC, we go back to historically appropriate numbers of patients. In the insurance-based system, doctors are very distracted, busy work, value metrics, etc. In the DPC, minimal busy work, minimal distraction. We are focused on our patients. Conflict of interest, intentionally injected under the insurance system. In DPC, we are the patient advocate. We are back to the way it should be. Access, pack schedules, hard to get in. DPC, same-day visits. Cost savings, much more expensive under insurance. Having all those middlemen drives up the cost, much less expensive under DPC. Now, if there's one criticism that has some validity, it says, well, there's a primary care shortage in the United States, right? Aren't you going to exacerbate this if you decrease the number of patients each doctor sees? Well, why do we have a primary care shortage? It's because of the third-party payer system. They've undervalued primary care services. People do not select primary care at a high rate right now coming out of medical school. In 2006, 2% of medical students had the goal of becoming a primary outpatient internal medicine doctor. That's what I do. I'm a dying breed. There aren't many of us left. But that's because it's undervalued. If people see this as a fun, enjoyable way to practice medicine, and they can make a good living doing it, more people would flock back into the primary care. So eventually, I actually think it would resolve the primary care shortage. So in summary, direct primary care, physician works for the patient. No billing hassles, new ways to access care through telemedicine, innovative ways to save money. It's patient-centered. Less bureaucracy, less paperwork, and more doctoring. So the future of direct primary care, doctors being doctors. Which brings me back to my original question, why did you go to medical school? Thank you very much.
If I can, just as a quick segue, I want to point out Dr. Fisher here is the head of the free market.
Oh, here I am.
Sorry.
Oh, I moved.
Oh. He does a lot of moving. I just want to give you kudos. You've been out in the forefront with this for a long time. Even though you're in a specialty around nephrology, he heads up the Free Market Medical Association. If you want to go back into some of the history that Chad was talking about how we got off the tracks here in regards to healthcare, he's got a book here as well that is well worth the time to read. So,
Thank you.
So any questions? Yes.
So what do you say to the family who says, okay, I have Blue Cross Blue Shield, I have wellness benefits, and I want this model, but how do I navigate that with my current insurance?
Yep, it's the PPOs, we don't tend to have a problem at all. I mean, they come and see us. You can make referrals for them. I make referrals all the time to specialists with the PPOs and some of the HMOs. HAP's not prominent over here, I understand, but HAP has a self-referral HMO. We don't tend to have problems with them. BCN creates a problem. To my amazement, when I first started, I had people ask me that question. They said, I have BCN, and I said, well, don't come to us. And they said, well, I really want to come. So unfortunately, there's some duplication that occurs for those patients. They have a listed primary care doc on their plan. They see them once a year for a no-cost physical, right? In the plan, well, they buried it in ridiculous premiums, but theoretically no cost. And then if a referral is needed, they go to that doctor for that referral. But most of the time, when we get MRIs for as little as $250 in my practice. And when somebody has a $3,000 MRI that's billed at a 20% copayment of $3,000, that means they would pay $600 with their copayment when we can get it for $250. So many of them just go, oh, forget it. I'll have that in case I'm in the hospital, but I'll just pay cash for everything because I got a $14,000 deductible anyway. So it's a little different for each person. The interesting thing is, you know, we were talking about this earlier, like Medicare and stuff. The less you control your insurance product, the less opportunity we have to decrease your cost. But it doesn't mean we can't decrease your cost. But if you can get somebody who even, it was going to be $600 a year and you got it down through making their meds and everything else cheaper, and it ends up being $70 a year, but they got much better care. And if they don't see the value in that anymore, well, then that's somebody who this is not the model for them. But most people are going to go, wow, that's like concierge. Oh, I heard concierge like $3,000 a year. But I'm getting that, and it's only going to be $70 more over the course of the year. I'm in. You know, there's a huge amount of population that really understands that.
You know, and I think there's another possibility. You can tell that patient to go for the lowest price, Blue Cross Blue Shield.
Right, right.
So, and then show them the savings. I'm sorry. And show them the savings that they can accrue, and they'll be amazed.
Right, so probably their copay is gonna pay for the.
Exactly. And then if they go, as Chad showed you, the lowest price Blue Cross Blue Shield, I mean, they're gonna save $10,000 to $15,000 a year.
Right.
I mean, just imagine that.
Right.
Yeah, the only negative being is some people don't have, like I see this with my union patients. A lot of my union patients have creme de la creme, which means ridiculously overpriced, insurance products, and they have no ability to select something else. It is sometimes hard to show them with no ability to decrease their cost that it's actually cheaper, but it is always better. Even if it's not always cheaper, it's always better.
Quality.
Yeah.
Anyone else?
Yes, we work for a heart specialist, and we were told, we contacted some of our insurance carriers, they said, you know, no, you have to bill your insurance, you know, that's in your contract. And we did get the information, I think you guys faxed over. I don't think they've given it to our attorney yet or anything, but it's, you know, it makes us think, oh, we shouldn't do this, because, you know, do you have to have them sign something saying, we don't want you to bill our insurance? So we have it in writing, because what if they come back and say, why didn't you bill my insurance? You know, how do you keep it straight as to, do they want it billed or do they not want it billed?
No, that's an excellent one, and we get it on the DPC side if you have Medicare, because they're going to still be seeing some Medicare patients, and that creates some potential leak snafus. So you'd have to look at those contracts, because if they have an insurance and you don't bill that insurance, and instead you bill them directly, that may be a violation of that insurance contract, so that's a legitimate issue. I know there are some that are doing something around like having them sign off and saying, I'm not billing my insurance, I don't, you know, and they're disavowing that. But I don't know if that would work. You'd have to talk to your attorneys about it. But that doesn't mean you couldn't offer it to the people who can use it, who do have, you know, Christian health sharing, no insurance or something. So there would still be at least a portion of the population, no matter what, who could benefit from those reasonable pricing. Whether someone who has BCN at $14,000 and chooses not to use it. I get docs who don't take those insurances, and then no problem, because they're not violating any contract. But if you take it and refuse, yeah, that is a potential snafu.
Anyone else?
How about your charting? Will you still use EMR, or will you go back to hard copy charting to?
Yeah, we'll still be using an electronic health record. We're going to switch to something called Elation, which is very patient-centered and very patient-focused. So there's a lot of accessibility between patients and their providers. So for emailing, for sending us texts, for sending us photos, for watching your Fitbit steps. I mean, there's all kinds of stuff that this allows us to do to improve care.
Can I make a comment?
Actually, on that note too, we also, it's got a, what's it called, a provider portal that we want to supply to all the specialty offices because we aren't part of Epic, and I know that sometimes causes a problem for some specialists that, you know, maybe didn't get our fax with our referral, but that way we can provide you a way to access that record, you know, if we have a secure, if we have a patient in common. So that's the way we'd like to increase accessibility and make communication even better.
This is a favorite topic of mine. You know that the High Tech Act, which is the act that requires physicians to use certified programs. Certified programs, how does Epic and Cerner and the other programs get certified? Well, they got certified by giving certain politicians money for campaigns. And Epic, who now nets $1 billion a year, gave certain candidates $10 million in their first campaign. And the High Tech Act was part of the stimulus package, which was a job promotion program. Right? So it's a job promotion program for programmers. Okay? The average physician cost per year is $40,000 for a high-tech certified program. An average hospital cost for a certified program is $100 million a year. Okay? You can go to Atlas MD and get a direct primary care program that has all the bells and whistles for $300 a month. So your cardiology group, I have no idea, what program they're using, but it is probably $40,000 per cardiologist. And all that is doing is supporting Epic and Cerner and the rest of them. It is complete fraud, and it's causing your cardiologist and your staff, which I'm sure you know, putting in all kinds of data that is totally useless.
And as an elected official, I can corroborate exactly what he's talking about. That was federal act that he was talking about. They attempted to do the same thing at the state level, and I fought it, and we actually ended up killing it so far, but most of the time it's kind of like Princess Bride, who's mostly dead. But so you always got to be vigilant. But that's what they do. It's nothing. It's not really unique to healthcare. It's a protectionist approach via legislation, but it's the same thing with maintenance of certification, a few other areas as well. So it's something you constantly got to be vigilant about.
I mean, can you imagine what your cardiology practice would do if indeed their yearly electronic medical record went from 40,000 to 3,000?
Right, they are kind of forced into it. at
No,
some
no
point
question.
Because they're
Absolutely.
in the hospital.
That's
They
true.
want to treat them. I mean, believe me, they took a long time deciding to get what we have, which you all might know is everything.
There's no question.
Yeah.
Yeah, and I don't know about the local hospital system, but a lot of hospitals make their specialists do it.
That's right.
And in fact, they
It's
charge
coming to
you
that
more.
point.
They do that because, and they say, oh, it's for the patients, for the communication. But they do it because the hospital gets a discount by forcing their outpatient doctors to do it.
But just
A lot of people don't.
imagine the world would live in if every specialist in the country said, no, we're not doing it.
Well, I get the whole insurance thing because that's what we do. We work for we try and get the back end billing.
I
We
mean, the
know
whole thing is
everyone
nuts.
requires different hoops and
Right.
things to jump through, and I see how difficult it is. And it is a pain in the neck, but I don't know any way around it for us at this point. But I applaud you for doing it.
Well, the more
because
docs that are doing this.
I think primary docs, it is a wonderful thing to do.
Well, eventually,
But the cost of cardiology,
I'm going to make a prediction.
Yeah.
10 years from now,
uh-huh.
half of the cardiologists in the country will not be participating in this craziness.
Do you know how much you guys charge for a stress echo?
I have it in my notebook. Do you know what you do?
I know because we have a cost.
I wrote it down because I have it.
But it doesn't really matter how much you charge.
Yeah.
It's
Right.
like,
Okay,
back to the
Yeah, I think
reasonable
it is
customary
quite
for what's the insurance fee schedule.
Then, but I mean, it's not what you get, you get something different from everyone.
What do you think would be like your average rate from
We
the,
heard 950.
you know what we get them for? $207. And my cardiologist makes an income, makes a profit on it. So everything's overpriced.
Right.
Oh.
It goes on to the top payer.
And that's because she doesn't-
You almost have to survive because you have other insurances that don't pay you anything, or they don't pay you at all because you didn't get the office at the hospital, you didn't, the hoops weren't jumped through.
Yep.
Which is terrible.
Accounts
but I
receivable,
don't-
right?
Yeah,
Yeah, they're huge.
it's
You know,
all-
those are going up in the United States too. As the premium cost goes up, the people have less money to pay the actual bill. So we are actually having an epidemic of accounts receivable. Doctors are having more and more bad debt because the patients are left with fewer and fewer dollars to actually pay for medical services because they're giving it to the insurance companies who aren't paying for those services.
Right, they pay.
So they're essentially
they
paying for
covered
nothing.
And they pay a premium and the deductibles, yeah,
Yeah.
we see that. It's like the Medicaid deductible plan, you know? Okay, they have a spend down, well, that's great, well, how, they don't ever pay
Can't
the
spend
spend
it
down.
down.
To me, I think
Yeah.
the spend down should be paid to the state, and that's.
No money left over.
Yeah.
You know, it's funny because it's insurance as a tool, as a financial tool, the concept is to prevent financial calamity. It's to cover a rare catastrophic financial loss.
Which should be
But
what
now,
they have.
insurance is that catastrophic loss. It's become the very thing it's supposed to prevent.
Yes, in the back.
Yeah, I was wondering how you get the right mix of patients so you don't have a bunch of patients that are all sick and going all the time. I mean, you say, how am I need to attract healthier patients or something like that.
I will take that question. One of the real critiques of direct primary care is, well, it'd be ideal if you can get about 6 or 7 125 or 30-year-olds. They'll see you maybe once every year, and then you'll never have to work, and you just sit there and collect money. Actually, one of the goals for us is to try to attract as many patients as we can who need medical care. So whether that's somebody who has no insurance or Medicaid or has Blue Cross and they have diabetes and hypertension and chronic kidney disease. So our goal is to just take care of patients. So we're not really trying to create a mix. I think that's what our goal is, just to take care of whoever calls us and signs up. So if it's the 97-year-old with 10 medical problems and, you know, we need to spend a half hour, 45 minutes with them for an office visit, we're going to do that. So we don't necessarily have a particular demographic that we're going after to really carve off the top, because I think that sometimes is an accusation in direct primary care is you guys are just trying to skim all the easy patients off. Actually, it couldn't be further from the truth. We're looking for as many patients who are needing primary care services, and if we end up seeing them 4 times as many times as our current number of visits per year, we'll see them 4 times as many. So that's fine.
I would also add to that, I think it's unpredictable who's going to need what type of health care. You know, I could have a 25-year-old who's been very healthy, but then develops chronic anxiety, who I spend hour-long visits with every month, you know. It's unpredictable who's going to need what care at one point in their life, and so I think just seeing whomever values our care is who we want to be seeing.
Yes.
How did you come up with the number of patients that you're going to see? Like the number of patients that you're going to have?
Yeah, well, we're not the first to do this, so we're basing it off of what has worked with other practices. So this has been a model that's been around for about 15 years and has been kind of gaining traction pretty rapidly over the last couple of years. And we're just looking at how other practices have functioned, and we've seen what other physicians seem to be able to do well with, and it tends to fall within that range of the 600, 700, 800 number of patients.
The direct primary care community is very giving. It's a very giving community. People are willing to help out. Like Dr. Savage took the whole day off from the east side of the state to come help us out. He's answered numerous emails to help us along the way. So we're not guessing. We're using people's experience and expertise, you know, their experiences over time. Other questions? Yes.
I'm just thinking I'm kind of cheap, and if I paid in my monthly fee, which, you know, sounds reasonable, but then they said, yeah, you really should go to a specialist. And I said, is that going to cost more? And they said, yeah. And I say, well, can you just take care of it? And would there be a pressure from patients to not send to a specialist?
Simple answer, yes. People want to get a value. So they do push us more. But I'll be honest with you, our system, we're underutilizing primary care doctors. Other health care systems around the world, they have 70% primary care, 30% specialists. In the United States, we have 30% primary care, 70% specialists. And in fact, it's a very bizarre payment system. Because if you think about the CPT billing rules, you actually, if you see someone and it doesn't require medication, and you talk to them and you address their issue, you can bill at 213. But if you give them a drug, it's now 214. And actually, that may have taken less time. Here you go. bye. And now you got paid $60 more for not really maybe trying to see if you can do lifestyle modification or other things, whatever it is, some non-pharmacological way of addressing it. Or alternatively, boy, you got stage 3 chronic kidney disease, your GFR is 59. Oh, I don't know, just go see the nephrologist. Well, now the coding system, even though that's ridiculous, we could have easily used our training to address these kind of minor issues in the earlier stages. There's actually a financial baked-in incentive to make that unnecessary early referral, which are you a nephrologist?
No.
Oh, I was going to say, because,
Never.
yeah. What was that, sorry? What was that?
He's sitting next to one.
Oh, yeah.